A very good morning to everyone. Thank you, Dr. Balla, for that kind introduction and having me in this IC. Well, these cases have been increasing nowadays because either it will be a combined surgery or a post-retinal surgery when you want to plan a cataract with a silicone oil removal. So you need to know certain things in this case because these cases will present with a set of different problems preoperatively, intraoperatively, and postoperatively. We'll just go through this individual aspect in my talk now. So what we have to assess preoperatively is, what are the challenges we need to know is we need to assess their vision properly to prognosticate. Fundus assessment becomes difficult if there is a dense cataract, oil-filled eyes, and high myop cases wherein you can't see periphery very well. So these are the challenges which you have to know. Biometry poses a different challenge. I'll be talking on that later on. Silicone oil in the anterior chamber, when the anterior chamber is completely filled with silicone oil, assessment of your grade of cataract, the support of the nucleus, all this becomes very difficult. Corneal related issues when the patient has undergone a vitrectomy for a trauma, wherein there are trauma cases and the corneal scars are pretty common in challenges which we'll have to assess. So biometry in oil-filled eye becomes a challenge where most of these cases wherein you have all these biometers which have a silicone oil-filled eye mode. Nowadays you get 1000 centistroke or a 5000 centistroke oil mode in most of these biometers already feeded. So you get a good accurate, near accurate biometry readings. But most important what I feel is you should always have the other eye biometry also be done unless we are dealing with anisometropia. So other eye biometry, both eyes biometry is usually preferred so that you have a fair idea for the comparison. Especially if the patient has undergone a scleral buckle, then there will be elongated eyeballs. The myopic shift may be around 2 diopter. You may have to be aware of this point wherein you will face anisometropia, and your biometry should be customized accordingly. Corneal scars in the trauma cases, as I said, will have a lot of astigmatism. You have to have these things in mind. So this is what I was saying, you have to have a preoperative refraction of the patient to have a fair idea of the biometry so that you are not heading for a post-surgery refractive surprises. It's very common in high myopes, especially wherein you'll have a surprises even if your data is very accurate. What are the special intraoperative problems when you are doing the surgery is if it is an oil-induced cataract, then the cataract will be very leathery, hard. You'll have small pupils because of the synechia already. If the patient has undergone surgery. The anterior chamber either can be very shallow in oil-filled eye or it can be very deep in a high myop patients. There will be PC plaques if there is a lens touch or if it is a oil-induced PC thickening. So these are the main intraoperative problems we need to do. If the pupil is small, use hooks, rings, whatever works better in your hand. Runaway axis in the intermittent cataract is pretty common. We should be aware of these things. And leathery cataracts, you preferably to a direct chop. The zonules will be very, very, very weak in most of these cases because they've already undergone multiple surgeries. So you need to be aware of this. So you don't have to put a lot of stress with your phaco probe on the zonules. If there is a lens touch or a PC dehiscence, which your retina surgeon would have already warned you about, so be aware of such situations. Well, hypotony is very tricky situation in these cases, especially if it's a vitrectomized eye and there is no oil inside, just vitrectomy is being done. So intraoperative, postoperative hypotony are very, very common. You have to have a perfect tunnel, use liberal viscoelastic. This will maintain the anterior chamber very well. Titrate your flow in such a way that there is not much AC fluctuation. Deep AC is very, very common in high myopes, wherein you'll have to literally bend your probe to a 90 degrees to even capture the lens in some cases. Emulsified oil like this in cases wherein you will be surprised to see the grade of cataract sometimes, wherein you have to first go ahead with the AC wash to assess the grade because preoperatively you would have not seen. These are the challenges which you have to take on table. Decision has to be done in most of these cases. So when you're designing your section also, you need to have a careful two-step, three-step tunnel with a sharp keratome. Don't use blunt instruments, which is already discussed in the last talk. Don't hesitate to take a suture after your surgery in most of these cases, because there's no vitreous, the eye will be soft, your tunnels may leak even if the best of your tunnels being constructed. So Rexis related problems, what would you face intraoperatively is there is no red glow in most of these cases. You may not be relying much on the red glow. Intermittent cataracts are very common, especially in young patients who have undergone vitrectomy, and if there's a lens touch, there will be intermittent cataract, and you need to manage the capsule very well. Use forceps scissors, stain the capsule. This is a video wherein a young patient we had operated for a retinal detachment. There was silicone oil, and if you can see, the lens is already intermittent. We are making the ports, we are staining the capsule. After staining, you can see just a small nick, and you have it there. You know, you recognize all these things on table and manage. Luckily, this was a very soft cataract. It was pretty easy for us to manage just by the aspiration with the phaco probe. We could manage it, place the lens inside, and then complete the rexis after placing the lens. Now, why I wanted to show this case was how do we manage. So this case was planned for a cataract with the silicone oil removal. So we have placed the lens. The rexis is being completed using forceps and scissors post IOL implantation. Now we are removing the oil. Once the silicone oil is removed, I'm using a cutter to manage this PC plaque, which is pretty thick, pretty common because of the oil-induced PC plaque. You can use a cutter, but preferably you have to do it after the oil removal. Don't do it with the oil, because the cutter won't work optimally when the oil is inside. So after the oil removal, you need to cut these PC plaques. As I said, handling the nucleus is also very important in these cases. Try to do a direct chop or a stop and chop, limited rotation manipulation, because you're not sure about the zonules. One very common problem which you have to be aware of in such cases is an infusion deviation syndrome, wherein the antechamber fluid goes behind the lens through the zonules. So wherein the AC will suddenly shallow and your iris will start prolapsing. Need not panic in such cases. You just have to do a sclerotomy and clear up the anterior hyaloid as much as possible. The fluid comes out very easily. You can leave the sclerotomy there for till you complete your surgery. I mean, the fluid, whichever is going behind the zonules, will be redirected through the sclerotomy. This I've already covered. So IOLs, you can use any of these IOLs. If there is a zonular weakness, use CTR, plan it very well. Use a larger optic IOLs, because it will be easy for the retina surgeon to assess the retina post-operatively as well. These cases are prone for excessive inflammation. Be aware of it. Posterior synechiae formation along most of these cases, the iris gets stuck to the IOL because of the excessive inflammation. So keep the pupil mobile after the surgery. Don't keep them on long-term cycloplegic. Keep the pupil reactive in most of the time. Cystoid macular edema is again a common problem if there is a lot of inflammation post-operatively. Worsening of PDR and macular edema in diabetic cases. So you be aware of this condition. Refer it to a retina surgeon if you see any early NVI or NVA which you can detect. And macular edema can worsen in all of these cases. So be watchful, do a OCT, and give an anti-VEGF as and when required. So take-home messages, you can always achieve very good results despite of the patient has undergone a retinal surgery. Meticulous intraoperative, post-operative, and pre-operative planning is very, very careful. Have a necessary equipments ready, because these are not the simple phaco cases. So all the equipments, what you need, forceps, scissors, everything should be ready when you take up these cases. Thank you very much.
Any questions for Dr. Sachin?
When is oil-filled eye, do you do in a two-step procedure? Like you remove the oil first and then do the cataract surgery?
Not necessary. You can go ahead with the same.
So biometry, what will be the difference of the
No,
IOL
yeah,
power?
most of these biometers come with the silicon oil mode in place. So these formulas.
Sometimes if we'll not, the other eye we can take or
Other eye we can. We always you should get the other eye done in all these combined cases and rely on a pre-operative refraction what the patient had, especially in cases if you are dealing with diabetics.
because few times you have got a refractive surprise when you do combine.
Yes, it is very common in myopes, wherein the RD itself will hamper your biometric reading if it is a pre-operative also you have done. So very high myopes that you will have surprises unless you are dealing with an anisometropia. If there is an anisometropia, then it becomes a big challenge. But otherwise, other eye and this eye as well you can do. Biometry should not be the only thing which should prompt you to take it separately. You can do it separately as well, but preferably you can do it with cataract, the same setting. Yes.
Yeah.
Can AC maintainer be helpful in some of the condition like hypertonia or suspected PCR during the RD surgery?
Yeah, see, basically, most of your phaco machines now come with a very good flow control. So AC maintainer makes no added advantage. Only if you are doing, if there is a PCR, when there is a rent in a post-vitrectomized eye, and you are unable to remove the cortex completely, or you need additional this thing, it can be challenging because you're pushing the fluid in two ways again there. It can shallow the AC immediately if there's a PCR already. So AC maintainer may not be required in most of these cases.
You don't use it as a...
No, not required.
I wanted to add one thing about the IOL. Sir was talking that if you have a huge doubt about the IOL bar, you can always tell the patient, I am planning oil removal and cataract removal. IOL can be put the next day. So you can do a biometry after the surgery, and maybe next hour also you can do it. In some cases where you feel there is a lot of doubt, patient is always happy with that. He'll never say no to a good IOL because putting in the IOL, wrong calculation, removing it and then again putting it, it is better not to put it, that surgery. Do a phakic biometry and then do it. So it is as easy as that.
And do you give anti-VEGF with the cataract surgery or you plan 1 week before cataract surgery?
You can do it with the cataract surgery itself based on the indication what you are talking about. If it is a diabetic macular edema, and you can do it on table as well. We don't have to do it 1 week prior, but it is always advisable to do at least 2 weeks prior because you have an optimal macular edema reduction, and the anti-VEGF stays in the eye till the post-op recovery is also there.
The calculation of the IOL power also may change.
Anti-VEGF will not change your IOL
the
power.
macular edema.
No, not really. Not really. Just few millimeters, so I don't think it will change much. Unless it's a massive edema, especially in cases of RVOs, when there's a CRVO or BRVO you're dealing with, then probably yes, I agree with you.